Hello, good afternoon, everyone. My name's Matt Brown. I'm one of the survey managers here at the Centre for Longitudinal Studies. Just a quick overview of what it is that we're going to cover this afternoon. So I'm going to start off the webinar by giving you an overview of the content of the Age 46 survey. I'm going to describe the questionnaire content, the biomeasures that we conducted, and various other measurements that we also conducted, and then there'll be some time for questions and answers when I'm done. Questions, by the way, you can add them to the chat pane whenever you wish, and I'll come back to them at the end of my section to answer them. And then following that, I'm going to hand over to my colleague Ellen Thompson, who's going to provide you with a descriptive overview of some of the early findings that we've found from some analysis of the data that we've done. And then there'll be an opportunity for you to ask Ellen some questions, and hopefully at the end there'll be time for any other questions which we've not managed to cover. And we hope to finish at around about 2:40. So BCS 70 is run by us here at the Centre for Longitudinal Studies. So I'm just going to say a few words about CLS. So we are responsible for the conservation, development and dissemination of three British birth cohort studies. So that's the 1958 cohort, the 1970 cohort that we're going to be focusing on today, and the Millennium cohort. And we are also responsible for running the Next Step study, which was formerly known as the Longitudinal Study of Young People in England. We're funded as a resource centre by the Economic and Social Research Council, and basically our remit is to collect data in these four cohorts and provide that data freely to the research community, which we do via the UK Data Service. And we also provide documentation, guidance and training, such as the webinar today, to help researchers to make use of the data. We also conduct a wide variety of research ourselves, both substantive research, and also we conduct a lot of methodological research looking into ways in which we can most improve the way in which we go about collecting data. This slide just gives an overview of the timeline of the studies. As I mentioned, we have four studies, the 1958 cohort, the 1970 cohort and the Millennium cohort. Those are our three birth cohort studies. You can see that there was quite a considerable gap between the start of the 1970 cohort and the start of the Millennium cohort. But then the Next Step study, which is not a birth cohort, Next Step started following participants when they were around about the age of 13, following those that were born in 1990. Nicely slots in to complete the time series. But I'm going to be focusing on BCS 70 today, so I'll come on just to say a few words about the background of BCS 70 before coming on to focus onto the most recent Age 46 survey. So for those of you that don't know, BCS 70 began back in 1970 when it was known as the British Birth Survey. And what happened then was that data was collected about the births and families of just over 17,000 babies who were born in England, Wales, Scotland and Northern Ireland in one particular week in 1970. So the early focus of the study was quite minimal. But over time, and with each sweep, the scope of the studies broadened so that as we followed the cohort members throughout their childhood, we were tracking various aspects of their educational, social and physical development. And then the cohort has been followed into adult life as they form their own families, entered the world of work, etc. And they've been tracked ever since and onto this day. So sweeps of data collection, there were three sweeps of data collection, three follow-ups following the birth cohort, which took place during childhood at ages 5, 10 and 16. So in those sweeps, the parents played a key role as respondents. They completed many detailed questionnaires about their children. We also collected information from the schools that the cohort members were at. So teachers completed questionnaires about things like their behaviour in class, how the teacher envisaged the study members' lives panning out. various other aspects of their educational progress, and we also collected lots of educational test results as well. The study members became also the core participant from age 26 onwards, and then we've had adult follow-ups at ages 26, 30, 34, 38, 42, and then most recently at 46. The childhood sweeps included quite detailed medical assessments, but since then, until the age 46 survey, we've not been able to do any objective measures of people's health. So, as I'll be coming on to say shortly, the age 46 survey has included quite a detailed set of medical assessments. So this is a really exciting new development for the study. Okay, so I'm going to move on to sorry, one more slide in terms of general information. So this slide just gives an overview of the numbers of people who've been participating in the study over time. So as I mentioned, at the start of the study, there were just over 17,000 study members. That included those that were born in Northern Ireland who actually weren't followed up in subsequent sweeps. So this slide focuses on those in England, Scotland and Wales, where there were just over 16,500 babies at the time of the birth sweep. And you can see that over time, that's gradually tailed off. Although from sweep to sweep, we have on occasion been able to increase the number of participants relative to the previous sweep. By the time of the age 46 survey, the most recent survey, we were successfully managed to interview just under 8,600 participants. And if you're interested in finding out more general information about BCS70, there's a whole wealth of information on the CLS website on the BCS70 study pages, and there's a link to that web page there, and we'll be circulating the slides afterwards. So there's going to be a few other links that we'll provide in the slides, so we'll send those round to you following the webinar. Okay, so coming on to look in some detail now at the most recent age 46 survey. So just briefly to describe it, so the first thing that we asked participants to do was to complete a paper self-completion questionnaire. This was posted to them in advance of any contact from an interviewer or nurse, and they were asked to complete that so that it was ready to collect when the interviewer paid a visit to conduct the interview. Then there was a substantial face-to-face interview, which included a series of cognitive assessments. So it was around about a 50-minute interview on average. That was then followed up by a 50-minute nurse visit with a whole range of biomeasures completed, which I'm going to talk about shortly. We also conducted accelerometry, so objective measures of physical activity in this sweep, which I'll also say more on. And we also asked participants to complete an online questionnaire about their diet. So the age 46 survey was funded as usual by the ESRC, but we also had additional funding from the Medical Research Council and the British Heart Foundation for this particular sweep. They funded the additional nurse visit and the use of accelerometry. So the piloting and development work that we did in advance of the main survey started back in 2015. And this was a very ambitious sweep of data collection. So there was an extensive amount of development work which took place over just over a year between 2015 and 2016. And then we started the main stage of fieldwork in July 2016. And the fieldwork period ran for longer than our typical surveys. It actually ran for 2 years. So fieldwork completed in July 2018. And as I just mentioned, the total number of interviews that were conducted was just under 8,600, which equated to a response rate of 70%. In terms of the content of the age 46 survey, so starting off with the questionnaire content, So as usual, we asked a very detailed set of questions about the household composition, so who the cohort members were living with, co-resident partners, any children that they lived with, or any children that they have that don't live with them, and any other people that we live with that they lived with, and movements in and out of the household. We asked a set of questions about cohabiting relationships and also about non-cohabiting relationships. We ask questions about each of the cohort members' children, and also whether the cohort members' children have their own children, so whether the cohort members are grandparents, and about any caring responsibilities which the cohort member has for their grandchildren. We had quite a detailed set of questions around social contact, so looking at how frequently people were in touch with various different people within their lives, so their children, their parents, friends, etc. We have a set of questions on people's housing situation. So this collected a history of all addresses that they'd lived at since the time that they were last interviewed, and also asked a set of questions about their current housing situation in terms of the type of accommodation that they live in, the size of the accommodation, the value of their home, and various other aspects of their housing. We have an employment and income module, which continues the economic activity history that we've been collecting throughout the cohort members' lives, and collects detailed information about their current situation, including their wages, their earnings, and the income from other sources. Given the biomedical focus of this particular sweep, we asked a very detailed set of questions around health, covering all aspects of physical and mental health and well-being. And we have detailed questions around various different health behaviors as well, so covering smoking, including e-cigarettes for the first time, questions around alcohol consumption, very detailed questions around exercise and physical activity, and questions around people's sleep and their diet as well. As part of the interview, we administered a series of cognitive assessments. So the cognitive assessments that we administered were word list recall, in which the participants are read a list of 10 words, and they have to immediately remember as many of those as they can. They're then asked to complete a couple of other assessments, and then following that, they're asked to recall that same set of words after a delay as well. So those assessments are looking at assessing levels of short-term memory. The animal naming task, in which participants are asked to name as many animals as they can within 1 minute, which is a measure of executive function and verbal fluency. And then the final assessment was the letter cancellation task, where the participants are presented with a grid of random letters on a page, and they have 1 minute to cross out as many P's and W's as they possibly can. And they're measured whilst doing that in terms of the accuracy, which is measured by the number of letters that they actually cross out, and the speed also at which they complete that assessment. So these assessments are a fairly standard set of assessments which have been included in a number of other studies, which will allow for comparisons between studies. In particular, these assessments were conducted in the age 50 survey of NCDS and will be repeated in the age 62 follow-up of NCDS, which is shortly going to be starting. The same assessments have also been included in the English Longitudinal Study of Aging and also in the 1946 cohort. But this is the first time that these assessments have been conducted with participants who are aged under 50. And so the reason that this was considered important is that there's emerging evidence that that cognitive decline can set in prior to the age of 50. So it was considered vital to get this earlier baseline measure of cognition, so that when we repeat these assessments in future sweeps, we'll have that baseline measure from an earlier point. Okay. So coming on to describe the biomeasures that we included. So as I mentioned at the beginning, this is the first time in adulthood that we've been able to administer any objective measures of health. Obviously, BCS70 has collected vast amounts of self-reported information about health throughout adulthood, but this is the first time that we've been actually able to take any objective measurements. So this is a really exciting development for the study, and it's going to enable us to use, and other researchers, of course, to use the information which the study's collected over the course of its life to assess the longitudinal predictors of health in midlife. The intention will, of course, be to repeat many of these assessments in future sweeps so that the information that we collect this time around can be used as a baseline against which we can measure changes which occur in health as people age. And 46, importantly, is an age at which the vast majority will not be suffering from severe health problems or declines in health. So important to get this baseline measure of health at this age. And also, very importantly, the NCDS 1958 cohort had a very similar biomedical assessment when they were aged 44 to 45. So that's going to open up the possibility of conducting a whole manner of cross-cohort analyses. So the measures that we took. So we measured height, weight, body fat percentage, and waist and hip circumference. We measured blood pressure, a key measure of cardiovascular health. So the blood pressure measurement that we took was resting seated blood pressure. We took 3 measures of systolic and diastolic blood pressure, which were taken at 1-minute intervals following 5 minutes of rest. So that uses the same protocol that was employed in the NCDS Biomedical. So cross-cohort comparisons very much possible there. We had 2 measures of physical functioning, the first of which was maximal grip strength, which we measured using a Smedley analog dynamometer. We took 3 measures on each hand, the dominant hand and the non-dominant hand. We also measured people's balance, which is an important predictor of later frailty in aging, which might occur with aging. So to measure balance, we asked participants to stand on one leg for 30 seconds. We first asked them to do that with their eyes open. If they could successfully do that, then they were asked to repeat the assessment with their eyes closed, which is incredibly difficult. We also took venous blood samples. So these, the blood samples are used to conduct a series of immediate analyses. We will also be seeking funding to extract DNA from the blood samples. That hasn't happened as yet, but funding is being sought to do that so that we can do genotyping of the cohort members. And we also have stored some of the blood that we collected for future analysis. So that's there as a resource for researchers to use. If anyone has any proposals as to what we might be able to do with the stored blood, then you're welcome to get in touch with us. I'll tell you what analyses we've done with the blood so far. So we've conducted measurements of cholesterol and glycated hemoglobin. So those measures have been done on everyone who gave blood. So glycated hemoglobin is a measure of long-term blood sugar levels, so it's a potential an indicator of diabetes. The rest of the measures on the screen we were able to conduct for around about half of those that were visited this time around, but we hope to be able to conduct these analyses on the half that didn't have the analysis during field work. So we're seeking funding to do that too. So so for half of the sample, we have measures of triglycerides. So that's another marker of cardiovascular health. C-reactive protein, which is a marker of inflammation. which has often been linked to obesity and physical inactivity, and is associated with the onset of various types of disease such as diabetes and cancer, and also mental health and depressive symptoms. Insulin-like growth factor, which is also a potential influence on cardiovascular disease and diabetes. Ferritin is used to measure lack of iron in the blood, so it's a marker of anemia. And cytomegalovirus, so that's a herpes virus, which has been linked with diabetes and cardiovascular disease risk again, and also to psychological distress and cognitive decline. So, as I mentioned, we also conducted accelerometry within this sweep. So what we did was we asked participants to wear a thigh-worn active power device for 7 days. And so, as I say, the active power device is worn on the thigh. So that differs from some of the accelerometers that we've used in other cohort studies, which where the device has been worn on the wrist or on the hip. So the advantage of the active power, which is thigh-worn, is that the device measures the angle at which the thigh is positioned throughout the day, which allows us to very accurately distinguish between different types of sedentary activity. So the device can accurately tell the difference between standing, sitting, and sleeping, in addition to working like a standard activity monitor and being able to measure the hours of physical activity and step counts, etc. So we've got really very detailed measures of physical activity as a result of having done this. So this is just an example of a feedback sheet that we gave to participants who agreed to wear the device. So you can see here the 7 days on which this participant wore the device. So the blue time represents the time when they were lying down in bed. The yellow time is the seated time. The green time is the time that they were standing, and then the red time is the time that they were actually moving. And in the data set which we're going to be making available, there's going to be lots of very detailed measures of the time spent in these different states and the transitions between them. And also for those who are not so interested in the detail, we're also in the process of deriving some useful summary statistics, which will give kind of broad overviews of people's physical activity over the course of the week. The final thing that we asked people to do was to complete an online diet questionnaire. So the questionnaire that we used was called the Oxford WebQ. It was devised by the Cancer and Epidemiology Unit at Oxford University and has been used in a number of other studies, including Biobank and the Million Women study. So what happens is that we asked participants, we randomly allocated 2 days out of the 7 days following their nurse visit, and we asked them to complete the questionnaire on those 2 days. And the questionnaire goes through an inventory of all types of food and drink that they had consumed on the day prior to completing it. And then the information which they enter into the questionnaire is used to derive a series of variables which calculate their intake of a whole variety of different nutrients, so fats and carbohydrates and various types of vitamin, etc. So all of that derivation has now been done, and so these nutrient intake variables will be included in the data, which will shortly be available. And as I've just said, yeah, the data. So it will be the data from the BCS 70 age 46 survey will be available at the UK Data Service very soon, hopefully within the next few weeks. That's all of the data with the exception of the accelerometry data. The accelerometry data is is somewhat more complex to process and make and transform into a format which is usable by researchers. So that's going to take us a little longer to get that ready, and we hope to deposit the accelerometry data by the end of this year. There's lots of documentation on the age 46 survey already available on the CLS website using the link here. So on that documentation page, you'll find the full questionnaires. You'll find the technical report written by the fieldwork agency, which was NatSen, which gives full detail of exactly how the survey was conducted and includes very detailed protocols about all of the nurse-administered biomeasures. And we will also be shortly making available a user guide, which will be of help to anyone who wants to make use of the data that we've collected. It will highlight it will give an overview of the data collection process and highlight the key variables relating to each of the different measures that we've conducted.
Okay, thanks, Matt. Hi everyone. So I'm just going to give a brief overview of the initial findings of this new sweep, the age 46 sweep of the BCS. So one of the first things we were interested in looking at was whether there was a discrepancy between self-assessed weight and objectively measured weight in which we derived BMI. So cohort members were asked to self-assess whether they were about the right weight, whether they were underweight, whether they were slightly overweight, or whether they were very overweight. So this was just a question that was asked. And then there were objective measures of height and weight in which we derived BMI. So I just want to pull out two numbers from this table, and that's that males who thought that they were about the right weight, around 34% of those, 35% of those were actually overweight according to BMI cutoffs, and for women, around 14% of those who thought they were about the right weight were actually overweight according to those BMI cutoffs. So this actually tells us that self-assessed measures of weight aren't always accurate, and it's something to be mindful about, and also we can answer some sort of empirical, interesting questions about assessment and belief about one's own weight. Okay. Okay, the next thing we're interested in looking at is the blood pressure measures. So as Matt mentioned earlier, one of the great things about this biomedical sweep is that similar assessments were conducted on the 1958 cohort at age 44 to 45, so similar biomedical assessments. So that allows us to conduct some cross-cohort comparisons. And one thing we were interested in looking at was how blood pressure has changed across these two cohorts. And what we found is that for women, a slightly higher percentage of women have high blood pressure, but a slightly lower or a much lower percentage of men have high blood pressure. So just to note that these findings are also adjusted for those on hypertensive medication. So at the moment, this is looking like a relatively valid finding, but these are just initial analyses, so some further investigations need to take place. Okay, and related to that, one thing that we've also started to look at are the factors that are involved in differences in blood pressure. So as I mentioned, we have information on smoking status. So one thing I've looked at, and I've just got the results here for women, is that whether those with high blood pressure, whether those differences by smoking status are different in the BCS cohort. So as you can see, just looking at this, for those born in 1970, it seemed that current smoker. But so the top, sorry, I've just realised you can't actually see the categories. So the top 2 bars are those who currently smoke, the middle 2 bars are those who used to smoke, and the bottom 2 bars are those that don't smoke. So for the top 2 bars, you can see that for BCS 70, 14 to 15% of people, women with high blood pressure, currently smoke. And this is a higher percentage than those who used to smoke and those who don't smoke in BCS. So this is just an example of one of the factors that we can look at in order to explain the differences in high blood pressure. Okay, so the next thing we looked at was cholesterol level across men and women, and this is just for age 46 for the BCS 70. So what we looked at was whether the percentage of women and men who are categorized as having an unhealthy ratio of total cholesterol, and we looked at their working status categories. So just looking at this, you can see that the percentage of men with an unhealthy cholesterol level is a lot higher than the percentage of women. But specifically looking at the categories, it looks like those who are in the not working and unemployed category, the percentage is a lot higher for men in terms of having a unhealthy ratio of total cholesterol to HDL cholesterol. Okay. And finally, in terms of the biomarkers, we also looked at diabetes. So this is based on the measure of glycated hemoglobin. And we also looked at working status categories. So as you can see, also those who are not working and unemployed for males, the percentage is of having an unhealthy level of long-term blood sugar is a lot higher. For those not a lot higher, but slightly higher for those not working and unemployed. And for women, for those who are in non-managerial and professional roles, the percentage is the highest in terms of blood sugar levels. Okay, so that's just a bit about the biomarkers. So moving on to physical functioning in midlife, we wanted to look at grip strength and standing balance. And for grip strength, as you can probably predict, men had a stronger grip than women, that's expected. But when looking across the work status categories, we can see that men in non-managerial professional roles had the strongest grip strength in both the dominant and non-dominant hand. And for women, those in the managerial professional roles had the strongest grip strength in the dominant and non-dominant hand. Moving on to standing balance. So as Matt mentioned earlier, we assess this by asking cohort members to stand on one leg for 30 seconds with their eyes open and then again with their eyes closed. Most people could do this with their eyes open, whereas only a small percentage of people could do this with their eyes closed. And there are some differences in terms of working status categories. So again, those who are in managerial professional roles, the percentage was slightly higher of men and women who could do this with their eyes open. And similarly, the percentage was slightly higher for those who could do this with their eyes closed. Okay, so I'm finally going to talk about cognitive functioning in midlife. So we looked across men and women and working status categories. So firstly, for the word recall task, this is where cohort members were asked to read 10 common words, and they were asked to recall these words immediately and then 5 minutes later. Women slightly outperformed men in both the immediate and the delayed recall task, and those in managerial professional roles did slightly better than those in other jobs. And also for the animal naming task, again, women did slightly better than men in the non-managerial and professional roles, but not in the other two categories. And overall, those in managerial professional jobs did slightly better than those in non-managerial jobs and those who are not working. So this task again is where they are asked to recall as many animal names as possible in 1 minute. So it's a measure of executive functioning. And finally, cohort members were asked to conduct a letter cancellation task. So for this, what they had to do was they had to cross out as many P's and W's as they possibly could, and this was measuring speed, but these numbers randomly flashed up and they had to cross them out. So we have speed and accuracy for this measure. And for the speed results, we found that women slightly outperformed men, and those, again, in managerial professional jobs, outperformed the other categories. And in terms of accuracy, there wasn't a huge discrepancy in terms of men and women. Apart from those who are not working and who are unemployed, men slightly outperformed women. Okay. Oops. Okay, so that was a really quick whistle-stop tour of some of the descriptive data that we've been looking at. So these are very early findings, and we're only really aiming here to highlight some of the prevalences, the sort of sex differences and social class inequalities in health and functioning. What we're currently doing is we're doing sort of further exploratory work to look across all of these sort of domains in terms of the data that's available. So we're looking at weight and obesity, metabolic health, women's health, cognitive functioning, and mental health. And as Matt mentioned earlier, so the biomedical data that's available is a really great baseline for health decline. So I think it's a really important measure in midlife, and there's a lot of interesting questions that can be asked, and the data can be used in lots of different ways. So just to give an example, one of the potential research questions that could be addressed is how do health risks that start to affect work in midlife evolve across the life course, and what prevention or intervention strategies can be used to reduce this risk. So that could be things in the environment, or that could be things in terms of sort of health and well-being. Okay, thanks very much. I'm going to pass back to Matt.
Okay, so yeah, I just wanted to conclude by letting you know that plans for the next follow-up of BCS 70 are well underway, and this will take place when study members turn 50 in 2020. So the age 50 survey is going to involve a face-to-face interview, a longer interview than we were able to do at age 46, so a 75-minute interview. This is going to allow us to do all manner of cross-cohort comparisons with the data that was collected from NCDS participants when they were age 50 in 2008. So we are imminently starting work on the piloting and development work for the age 50 study, and the main stage of data collection will take place starting in around May 2020 and running for around about 18 months. So finishing sort of mid 2021 if all goes to plan. In terms of the likely coverage of the age 50 survey, we're going to be looking at household composition again and people's family circumstances. The social contact measures that we'll be doing have been expanded quite significantly. Housing, employment and income again. Detailed questions about physical and mental health and well-being. We're going to be repeating the cognitive assessments that we conducted at age 46. we're also going to be conducting some additional cognitive assessments as well. We'll be asking questions about social participation. So there's quite a lot of questions about attitudes, voting, use of technology, so screen time, use of social media, these very important aspects of people's lives. We'll also be asking a lot more detail about that than we ever have done before. And we've also got questions around workplace bullying and experience of domestic violence as well. So as I mentioned towards the beginning, there's a vast amount of further information about BCS70 and all of the cohorts that we run at CLS on our website. So I would strongly encourage you to take a look at that. If you have any questions at all, then please do feel free to contact us. You can use the email address there, clsfeedback@ucl.ac.uk. Something that we haven't touched upon today because of a lack of time is the importance of ensuring that when conducting analysis that we handle missing data and the impacts of attrition correctly, because obviously attrition is a significant issue in conducting longitudinal research and can potentially introduce considerable bias into analyses. So I wanted for now to point you in the direction of a paper by Tarek Mustafa and Dick Wiggins, which gives some advice on handling attrition when analysing data from the 1970 cohort. So there's a link there. And also I wanted to highlight the fact that we'll be producing a new guide to handling missing data across all of the cohorts in September, and we'll be running a training event for researchers going over our recommended approach for handling missing data in October. So look out for news about that. And so that's all we had to say, other than to thank you very much for coming along and joining us this afternoon. And we hope that you found it useful.